So it's interesting how this has evolved to a discussion around what is asymptomatic TR. And, I think I didn't prepare slides because I wanted to be able to, pivot based on the commentary and the thoughts that occurred to me sitting there. So if we look at the other valve diseases, AS, AR, MR, what's evolved in the last 5 years are studies of stages, right? So we look more and more proximal. You look at the valve for AS, you look at LV dysfunction, LA dysfunction, pulmonary veins, all the way to RV. So we have stage 1, 2, 3, 4, recognizing the chronicity and the impact and the poor prognosis of increased stages. You can debate whether they're stages, whether they have to follow a linear order, or whether they're just categories of risk with associated dysfunction. But we understand all the left side of the disease, and we're starting to look for the proximal stuff that makes the prognosis worse. Combining my two talks today in the tricuspid space, all the advanced imaging we have, we can now look at whole body MRI flow. I showed you one example of what was probably a vessel in the chest reversing. We know that the hepatic veins dilate. We know that the renal veins dilate. We probably have, if we look for it, evidence of changes in your gut flora. I mean, TR is a visceral problem. And all we do is ask somebody, okay, you're on some Lasix, how do you feel? I'm tired, but I'm 70. Okay. Are they asymptomatic? I don't think so. So I think what we have to do is improve how we define symptoms. We can look at RV free wall strain. We need cut points for RVEF that matter. In the mitral space, we have long understood that there are surrogates for symptoms. So you've got severe MR and you feel great. You don't necessarily go to surgery, but if you have pulmonary pressure elevation, if you have end diastolic dimension enlargement, if you have new onset AFib, we accept those are symptom surrogates. We send you for a fix. We don't have symptom surrogates for the tricuspid yet, but we should. And I think the imaging that we have will be imaging-based. I think that's how we're going to define our symptom surrogates. We have procedures that are very low risk, particularly the TEER. I think waiting for somebody to blow out their RV and to feel poorly is just a bad strategy. So I think we're going to change this. I think our debate topics will change in the next, the next couple of years. And I think that would be my final word, is that we are really bad at RV symptoms, and we need surrogates to help us get better. Thanks.